Dzień dobry, witam Was serdecznie w dzisiejszym programie. Dzisiaj będzie wyjątkowo, bo dzisiaj po raz pierwszy w historii będziemy prowadzić nasz live w języku angielskim. So, let's start. So, today we will be talking about retreatment. And retreatment is, by definition, a procedure with really increased level of difficulty. Retreatment of curved canals sounds like a nightmare to some people, but is it really that scary? Well, in this episode, our guest, Dr. Eugen Buga, will talk about this. He's a specialist in microscopic endodontics and he's well-recognized international lecturer, experienced clinician, and my very good friend. So let's talk about this subject. Hi, Evgeny. How are you?
Hello to everyone. Hello, my friend. I'm good. I'm very happy to be here, to be invited to talk about some interesting topic on the dentistry and endodontics, and hope that it will be a very good booster for our colleagues, for some young dentists who are very scared about these procedures of the treatment, or even more, the treatment of the difficult anatomy of the curved canals. And hope to have a great conversation today with you.
Yeah, okay, because you're saying about young dentists, and this is what I really want to talk about. And my first question is, what do you think? Is retreatment of curved canals or retreatment itself more difficult than primary treatment? Because lots of young dentists, they are really afraid about the endodontic itself. And when we are starting about talking retreatment and, curved canals, which are or should be more difficult, then they are so frightened. So what do you think about this subject, please?
Well, everyone who has attended my courses know that we are used to simplifying everything complex, and therefore the instrumentation of complex anatomy is lightning fast. If you have the right approach based on biology and understanding the principle of instrumentation. When it comes to the treatment of severely curved canals, complexity is, I'd say, definitely added in each of us and has each of us has faced certain difficulties in the process of the treatment, where you fell into the stupor and didn't know what to do next, isn't it? So, and we perfectly understand that the main enemy in the process of the treatment, it's not the filling material. The filling material at the beginning of the curvature, it's the main enemy. And when we have a combination, filling material and complicated anatomy, rarely do we have to retreat the straight canal. Usually we have even a small curvature, but it's still there. Often we encounter difficulties with some skinny premolars or molars, and this is where our ability to combine biological and technical skills to overcome these complex anatomical formations come into play.
Yeah, and that's good that you're saying that, because really, when we are discussing about the retreatment, we normally do not have a lot of these straight canals to be retreated. So in fact, most of the times we do the retreatment of the curved canals. And yes, I also attended lots of your courses because we are organizing this together. Yeah.
Well, I'm preparing something for you new on to show you how fast it can be on the treatment of the severely curved canals, because a lot of additional complicated information, how to manage some ledges or broken files or cements into the canal, but we need to filter all the unnecessary information and to keep it as simple as possible to achieve our goal.
Yes, that's true. Okay, so tell me something about another topic. What about diagnostics? Because when we are talking about the retreatment procedures, we need to have a good diagnostic. And is X-ray, I mean, the classic 2D X-ray enough in curved canal cases, or should we plan and execute efficient treatment only after requiring cone beam?
Well, very good question. People usually think that to be a professional, you need to be fully doted with all the equipment and to have a CBCT into the office, to have the last good aperture guns into the office and the motors, files, and so on. In fact, everything is simple. So any additional information, what we have, it's an advantage in determining the treatment tactics. A bidimensional image, in fact, is just a 50% of the information about the anatomy. And we don't forget that this bidimensional image is just, as I said previously, it's just 50% of the information. So having a CBCT into the office, it's an advantage, but you can use it just when you have a patient for for a complex treatment and the patient have a CBCT for a surgery or for orthodontic treatment, but we don't make a CBCT just to analyze the anatomy. So my answer is no, we don't do a CBCT to understand better the anatomy. We follow exactly the guidelines of the European Endodontics Association or American Association of Endodontics, where clearly writes when to use the CBCT. In fact, what is more important is to consider every tooth very complicated. That is why sometimes you broke a file or you make a ledge, because you lose so precious information on the image. And our protocols, what we discuss on the courses also, are directed to the most difficult cases. Not it's because we are treating just the most difficult cases. It's to be able to manage every case when you are ready to manage the most difficult case.
Okay, so maybe I will ask you a totally different question, but the question that we really have heard lots of times in our workshops is lots of, especially young dentists, but not only, but the doctors who are doing endodontics, should we always do retreatment when primary therapy isn't perfect? I mean, like incomplete canal filling, but there is no periapical lesion and the tooth is asymptomatic. Should we then do the retreatment?
Well, it's a good question, especially for unexperienced our audience. Firstly, what is perfect? It's a deliberately erroneous term that entails many heterogenic problems that lead to the tooth loss of for patient. So we have created some framework in our endodontic society, what is perfect and what is bad, unfortunately. This is not always associated with the evidence-based medicine, and young doctors trying to fit into these standards neglect the needs of the patient who is only interested in asymptomatic tooth on which he can eat. So this young specialist is trying to create this perfect treatment, wasting time and financial resources, but the worst thing is that the patient may lose a tooth as a result of these influences. So in the cases when I say the doctor's ego kills the patient needs, so we treat an inflammation, not an X-ray. So somebody will say, but we are still treating to prevent the appearance of the apical periodontitis. That's how it is. But don't forget that we can never remove all the bacteria and all the irritants from the root canal system. And we never know what the bacterium tolerance threshold is for a particular patient. That is, the presence of the bacterium in that apical part is much lower than the level that this patient can tolerate. So many people forget that drilling again the tooth with additional instrumentation of the canals, it will lose even more tissue from the tooth, which will make it less resistant to the occlusal stress into the future, which can lead to the losing of the tooth. And we are all aware of the Scandinavian studies, which say that often the patient will lose this tooth due to mechanical issue rather than endodontical issue. So no, case selection and planning, it's a must for everyone. This will turn process-oriented treatment into the patient-centered treatment. This is what we teach, and this is what we push to the audience.
And I really agree with you with this approach because, we all remember from our old times when we were starting that we wanted to treat anything always. And that was the biggest mistakes we were doing. Once from the
Absolutely agree.
From the points that you already mentioned, but then if we wanted more than the patient, then most of the time this treatment didn't work out, and then the problem started to become even bigger. But let's come back to the curved canals. We can agree together that they can be demanding, and we know that we do them on everyday basis. But let's talk about the risks. So please tell us, what are the risks we should be aware of before starting the procedure of retreating the curved canals?
Well, the main risk that I see today are the surrogate components in the products. The CANT, the ADGA, manual glide path, recapitulations, etc. So there is no magic. Everything is simple here. You just need one file to determine the length of the instrumentation and rotary files to combine the optimal ratio between torsional and cyclic fatigue resistance. Simple like that. No hand files. Less movements into the canal, less chances for creating an iatrogenic error. To summarize, main risks, in my opinion, are misunderstanding of the anatomy and hand files.
So, from what you just said, our audience should understand that you are not using the hand files for the retreatment. You are just using the mechanical files, right?
Well, everyone knows, especially there who attended my courses, that we are trying to minimize all our movements into the root canal space to make it fast and efficient. And less movements into the canal, less chances for iatrogenics, as I said. The hand files we're using just in the process of the bypass of the ledge, for example, or bypass of the broken files sometimes. If we are switching to the rotary files, our process becomes very fast and efficient. And I understand somebody will feel it uncomfortable when we're talking about the fully rotary instrumentation, but in fact, it's just a learning curve. Right protocol, right concept, right approach, and you will be able to retreat even a difficult anatomy purely rotary without even a hand files.
Yeah, and totally agree. But I wanted to just to emphasize this for our audience, because this is this is one of the important points of our discussion, that fast and efficient endodontics and the retreatment of any kind is much better with less movements, less introduction of the files into the canals. Okay, so right now I will ask you another question, which in my opinion is very important. So there are some types of curved canals. So which type of curved canals is the most difficult in your opinion, or maybe there are more than one, and then please explain why.
Well, definitely the most difficult and the most unpredictable are the J-shaped curvature. We have a lot of tips and tricks how to simplify the negotiation of the J-shaped curvature, but I will simplify the answer. It's because we have two components. We have the anatomy and we have a file. So the anatomy in the last 3 millimeters, that is why the surgery it's done, the apical surgery with the cutting of the last 3 millimeters, because in the last 3 millimeters we have the 98% of the additional anatomy. So when you have a J-shaped anatomy, in the last millimeters, you have the most complicated anatomy, and the file rotating in this canal, all the files with the increasing of the size have a tendency to straighten up. It means that it will work on the outer wall. And if you are in the J-shaped curvature, one of the files will get stuck in one of these additional anatomy, in the lateral canal on the outer wall, which will lead to the iatrogenic errors such as a ledge or blocks. So the J-shaped anatomy have a very spatial approach, and even then we are more unpredictable than with additional anatomy. So the J-shape, it's the most difficult and unpredictable.
Okay, but we have like some different types of J-shape. So would it be more stressful for the operator to have a J-shape in the apical zone or in the near to the pulp floor chamber?
Well, of course, the apical. The apical because it's the smaller radius. It's higher stress on the file. It's easier to broke a tip of the file because the tip become engaged to the outer wall on these apical irregularities, and it's easier to break a file. So apical J-shapes are the craziest.
The craziest. Okay.
Yeah.
Okay, so when we are talking about the procedure of the retreatment of the curved canal, if we want to mention the most important thing, what should it be when proceeding retreatment of the curved canal? The main important thing you can mention, just to help our audience to work with it.
So many usually attending the courses looking for a special recipe about what kind of file to use and which sequence. But in fact, what they get more important from the course, it's the approach. And in my opinion, the most important thing, it's planning. That is why we allocate a separate chapter to the planning of the retreatment and to the courses. After all, if you plan for a treatment, it's correct, you can solve the problem with the inflammation in a quick way, spending a minimum effort on it. The second important component, it's a clear algorithm for selecting the tools for passing the canal block and reaching that irritant extrusion zone. So the planning, when you can select the area of the extrusion of the irritant, make a big emphasis on that, having a right protocol of instrumentation. You know exactly what kind of tool you have to use there. Doesn't matter the brand of the file, doesn't matter the brand of the ultrasonics, you just know what to use for every case.
Okay. I really agree with that. And by the way, we are talking here about the preparation, retreatment of the curved canals. If you are interested, just here you have the address dentalkursy.pl, and you can find one of the workshops that Evgeny will have next year. It's going to be in April, right? In April, March.
Yeah. March. Yeah.
March.
Right.
I think it's March. Yeah, 11th and 12th of March. So check the page, because there is a registration form. We still have places, not all the places. Some places are already booked, but we just announced these workshops like 2 days ago. And of course, we are cooperating with Evgeny for years now, and we did lots of courses together. But this one is totally new. Okay, but I will push you right now. And you know that I'm a big fan of irrigation, and I really love irrigation.
Yeah.
And the question which I want to ask you is about irrigation. So is irrigation a key to clean and disinfect curved canal, or maybe we should focus on something else like mechanical shaping? And I'm really curious about your answer.
Well, somehow my position on that. So
Yeah, I
in
know.
fact,
I know that's why
we
I'm
are
pushing you.
we are concerned um, concerned more about the to solve the inflammation. And to solve the inflammation, we have to reach that area of the extrusion of the irritant outside of the canal. How we reach that area? With the instrumentation, of course, and the irrigation. It's important or not? Of course it is. Because the instrumentation, in my opinion, do the biggest job. It not just prep the canal, eliminate a lot of irritants from the canal, the debris, the organic tissue. And as we know that the root canal space is not perfectly round, so the irrigants comes additionally to eliminate that free position of debris on the irregular areas, to dissolve organic tissue, to kill the bacteria. So of course it's a symbiosis between these two components. But in the same time, we need to understand perfectly that for irrigation we need some condition. And in the curved canals, they are more difficult because we are not able to enlarge always up to number 30 ISO to have the irrigant there. In the same time, we are not able to deliver our irrigation needle so close to the apical part. Yes, on the market comes the Irriflex, which solve this problem with the metallic needle. But still, it's not always possible to deliver irrigants apically. It's important to realize this, and what we see in the orifices is not what we have apically. Sometimes it's possible to deliver irrigants there, sometimes not. But fortunately, what we do usually, it's great impact to decrease the number of the irritants from the canal mechanically and with the irrigants to give the patient a very small amount of the bacteria left into the canal, which lead to the healing and to the relieving of the symptoms.
Okay, so what irrigants do you use in curved canal cases in your practice?
Well, in curved canals especially, it's important to avoid using the lubricants. And why lubricants? Because there is the EDTA. So again, the irrigation with the EDTA. If somebody think that the EDTA open the dental tubulus, eliminate the smear layer, and increase the impact of the treatment, then he can do that at the end of the treatment, not in the middle of the procedure, because it can lead to the ledge formation. Because of the action of the ADTA, it will create the demineralization and will softening the dentin. So all the procedure is covered with the sodium hypochlorite, higher percentage, because there is no very high impact on the price of the hypochlorite, so everyone can afford to use the highest concentration of the hypochlorite. It's the faster, it's the better over the organic tissue. Additional irrigants, I'm not using the chlorhexidine. I'm not using the ADTA. Why? If some of you still using the ADTA and wanna listening my opinion on that, we can discuss with the slides and pictures to the studies why personally me not using the ADTA so often.
Do you use solvents in retreatment cases? Do you recommend using them?
Well, the idea of the solvents comes into the field of endodontics because the specialist and the general dentist especially want that magic pill which will solve the problem with that blockage into the canal. And using of the solvent into the canal, into the canal to bypass that block or that blockage of the gutta percha, usually do to create a very easiest path to the false path and to the apical perforation. If we are talking about the apical anatomy, we know perfectly that the last millimeters of the canal changing the direction, and if you have that apical stop and you continue to pull thinking that there is just a gutta percha using a solvent, you will create just an apical perforation. What about the efficiency? Well, efficiency is very low. The most important, most used solvent efficiently is the chloroform. Unfortunately, it's quite dangerous, and not for a patient. It's more dangerous for us because we inhalate that vapors. So we are not using that. The eucalyptol and orange oil action have a very slow action. It's oil-based. It's impossible to eliminate from the canal walls. It's a huge allergen. What I'm trying to say that what I'm doing with the rotary, I can do it in the very, very fast way. It's a high speed of the rotary, special rotary for retreatment, not retreatment files, using the high speed. It's about 1000, 1200 RPM with a high torque, directly into the gutta percha, and with the high speed of the rotary files, softening the gutta percha, you can advance it fast to the apical part. How to manage the last millimeter with that high speed, it's very important to know clearly the protocol. It's not just like put in and just go to the apex. You need to know exactly when to stop, what are the orientiers, and how to manage the apical end. But by rotary, you can do it much more faster without waitings, like in that meme with Pablo Escobar, waiting to the solvent to action. Okay, so no, I'm not using the solvents, not for me.
I totally agree with you, because you know that I'm not using them at all, totally also. Okay, Evgeny, last question, but I think that this question will be very interesting to our audience, is I will not ask you about dealing with broken files in such curved canals, because of course this is a very interesting subject, but we don't have enough time to discuss it. But I will ask you a little bit different from the other side. How to avoid separation of the file in endodontic space? Because you're doing the retreatment, you are working in this canal, very curved or delicate curved canals, and lots of dentists are afraid about separation. So are there any practical instructions, maybe your tips and tricks, how to avoid separation of the file in these kind of treatments?
Okay, first of all, the general suggestion for everyone is, do you use the new files always for a new case? If you can, financially, why not? It's good. But we know that we need to choose the weapon, the arrow, which can solve every case and many times. I mean, the rotary files you use need to be very resistant to torsional stress. And explaining more, I mean, when the file have that stress on it, it will just unbend firstly, you see, and you can change it. Come back to the my suggestions. First of all, I suggest you to read carefully the not you, my friend, I know you wrote it to the audience, to read the Max Padden book, Mastering of Instrumentation.
That's an amazing book.
Yeah, and for some rules from there, it's not to leave the file to be engaged more than 3 millimeters into the canal, eliminate the file, clean the fluids, inspect the file, then go again. Most of the time we broke a file because we are tired, we are not inspect the file, we are continue to pushing. The file will not cut because it become overloaded by the debris, and you continue to push, which lead to the iatrogenic error. So suggestions will be clearly use a good torsional resistant rotary files. How to select rotary files? I strongly suggest you to attend one of my courses when we have a special topic for choosing the right rotary file systems. But the torsional stress is the main component of the file. Of course, it have need to have also a cyclic fatigue resistance to be quite flexible. And the most important is to keep in mind the apical anatomy. Apical anatomy, very complex, going not as you see on the X-ray straight on the straight exit. It may have a lateral opening, and you need to know when to stop. And keeping this in mind, inspect the file. Don't use unwinding files. It will prevent you to save more files. I'm not talking about the not to break files, because to break a files it's really difficult if you have a right rotary file systems. All the rotary file systems on the market are good, but we are looking for the best ones. So you need to know exactly the parameters of the rotary file system you are using, the torsional stress and the cyclic fatigue, and the combination between them, 60 to 40% of the properties. Which ones? Hope to see one of my courses to discuss more in depth.
Just one question from the audience. Can you repeat the name of Max Spaden book? The title?
Mastering of Instrumentation Techniques.
Yes. I can mention from my position that also read this book. The book is amazing and it's really worth every penny you will spend on it, and every moment you will spend with that book, because the book is really amazing, and Max Spaden showed everything what you want to know about mechanical preparation.
Yeah, definitely. So I will just feel a little bit. So there is everything you need to understand about the files. So the cross sections, the metallurgy, the helix angle, the cutting edge, and everything. So it's like a axioma you need to learn. More you know, more flexible you become in your field, and this is what we learn at our courses, to be patient-centered and to have a very efficient, without surrogate protocol.
Evgeny, thank you very much for this nice conversation. Really enjoyable. Thank you for all the tips and tricks you gave us and all the information. And we see each other in March in our center for the international training on retreatment of curved canals, but in the easy steps.
Yes, exactly. We prepared already all the models with the curved canals, with the fiber posts, with the broken files, with the perforations, and on the practical part will be hard. So trust us, they will be the same hard as the instrumentation of the curved canals. Preparing something special for you.
Thanks again, and
thank you for invitation, my friend. Thank you.
My pleasure.
Bye bye.
Dziękuję Wam serdecznie za udział w dzisiejszym programie. Thank you very much for attending today's program. And I invite you for another programs which will take part every Tuesday 9 p.m. Zapraszam na kolejne programy, które będą odbywały się jak zwykle o 21 we wtorki. Do zobaczenia już za tydzień.